Please welcome to the stage NCCI's practice leader and senior actuary, Barry Lipton.
Hello, folks. Thank you for joining me this afternoon. I'm thrilled to be presenting NCCI's research to you. We're going to be covering 3 topics. My main focus is going to be a comparison of workers' compensation medical costs to that of group health. After that, we're going to take a look at the experience rating plan through a predictive modeling lens. Finally, I'm going to give a brief update on mega claims, those claims greater than $10 million. Why group health? Well, if you combine individual and group health medical payments, it's 30 times the volume of workers' compensation. It really is the market price, a much better benchmark than Medicare. So let's get into it. If we look at the coverages, group health covers a wide variety of illnesses and injuries, but the coverage horizon is 12 months usually, the length of the policy term. In workers' compensation, we have a narrower array of illnesses and injuries. They have to be work-related, but the coverage horizon is tremendously longer, the lifetime of the injured worker. If we look at regulation of the 2 lines, we see that workers' comp is primarily regulated at the state level. Statutes and regulations determine compensability, fee schedules, choice of provider, a whole host of issues. Group health, on the other hand, is regulated at both the state and the federal level. However, if you're an employer-sponsored, self-funded group health plan, you're likely covered by ERISA, which preempts much state regulation. If we compare the cost controls, we see commonalities, drug formularies, provider networks, prior authorization and utilization review. Those are in common. In fact, workers' compensation borrowed the first 2 from group health. But there are some key differences. Workers' compensation is unique in that most states have fee schedules, a schedule of maximum allowable reimbursements that set a cap on the price that workers' compensation providers pay. Group health, on the other hand, has cost-sharing mechanisms, deductibles, co-pays, co-insurance. All those have the effect that patients are more conservative in their utilization of medical services. Work comp has safety programs. Group health has wellness programs. But as we heard from the key physician panel, key focus in workers' comp is return to work. And that's really a differentiator. So what were some of our findings? Well, when we looked at prices paid, we found those were pretty comparable. It's the volume of services that drives the cost differential. We found that work comp costs for radiology improved. Physical medicine remains an opportunity area. And there are smaller cost differences for acute injuries than there are for complex injuries. What do I mean by acute and complex? Well, we used 12 injuries to do the comparison, 6 acute and 6 complex. The acute were in general breaks and sprains of the extremities. The complex were primarily back cases, spine cases, but we also included hernias and bursitis. So now let's look at some numbers. The blue bar shows the average price differential between work comp and group health at 112%. On most of these slides, the white line will represent the 100% group health reference line to help you with the scale. Now, in this study, we've controlled for injury mix, age, gender, and state. So we didn't control for the service mix. The 112% is a combination of pure price and mix. But you know, whether it's price, mix, 112% is, maybe that's not that bad a number considering we want the physicians to focus on return to work. In a lot of jurisdictions, there's extra paperwork in workers' comp. So price doesn't seem to be the issue, it's the quantity of services. The differential on volume is 160%. In other words, workers' comp does 60% more services than group health on similar injuries. And the combination of these two factors leads to a total cost differential of 177%, or 77% higher. If I show the results by state, here I've used a heat index where white is close to 100%, i.e. group health, and deep blue is around 300%. We can decompose the cost differentials like we did nationwide. Blue is price, orange is quantity, green is cost. On this slide, I've drawn white lines at the national relativity, so you can easily tell whether a particular state's component is higher or lower than nationwide. Let's illustrate it with Colorado. Here we have the blue line being significantly lower than the nationwide average differential. The orange bar is higher than nationwide, but not so much that the total cost loses its advantage. It's still lower than nationwide. We have 27 states. We'll be posting this presentation on the website so you can all have a look at your favorite state. So once again, here's the next set of 9 states, and you can see by the white lines that some are lower significantly than nationwide, some are higher, quite a bit of state variation. Here's the last set of states, again showing a lot of state variation. One thing that's in common though, in almost always the orange bar, the quantity that's bigger than the price differential and driving the total result. Now, if we look at it by service sector, we have evaluation and management, physical medicine, radiology, and surgery. The blue bar for evaluation and management is below the white line at 100%, indicating it's actually lower than group health. However, the orange bar, quantity, that differential is 153%, leading to a total cost differential of 132%, or about a third higher. Physical medicine, the blue bar shows a very modest price differential to group health, only 105%. But it's the quantity that's very high, leading to a total cost differential of 291%, almost triple. Radiology's total cost differential is 138%. We were favorably surprised by that. I'm going to talk more about radiology in a minute. The surgery differential is 170%, driven primarily by price. The quantity is only 110%. You know, I'm glad to see we don't do dramatically more surgeries in workers' comp than in group health on comparable injuries. Now let's focus again on radiology. We did this study once before and published it in 2006. Back then, the differential, when we restricted it to 90 days post-injury, as that was the study basis then, 276% differential, comparable to physical medicine. Now it's only 132%. The 132% differs slightly from the prior slide because this is restricted to 90 days post-injury, but it's basically the same number. So let's look more into what might be causing this. Why are we so fortunate as to have this decline in radiology costs? Here I'm going to pick a single MRI treatment to focus on. This is an MRI of a knee or an ankle without contrast or dye. The blue bars show the average price for this service. 2011, it was $672. It's declined to $514 in 2017. The white lines on this slide is the group health average payment. It's right in line with work comp for the years we have the group health data. So there's a significant decline. It's not just a mix issue. If we look at the maximum allowable reimbursements that I referenced before, This is the average across all the states in the study. $999 in 2011, declining to $739 in 2017. The green bars show the Medicare reimbursements declining from $411 to $240 over that same time period. They seem to be pretty correlated, and that's no surprise. About 2/3 of the fee schedules are actually based on Medicare. Now, when Medicare makes a change, it doesn't mean the state adopts it in the very same year. Sometimes it takes a year or two to work its way in, but this pattern isn't surprising. But at the state level, it can vary quite a bit. So here we're going to illustrate what's typical in a state with a Medicare-based fee schedule. The maximum in this state was $1,158 in the beginning of the study period, dropping by more than half to $541. The average payments shown in the gray bars following that drop, it's pretty clear that the maximum allowable reimbursement is having a strong impact on the average payment. Remember the 2012 maximum allowable reimbursement of $1,113 for a moment, because I want to compare it to a typical state whose fee schedule is not Medicare-based. Here in 2012, it was $1,147, very similar. But instead of declining like it did in a Medicare-based fee schedule state, it actually went up slightly. And the average payments in the gray bars don't show the same type of decline that we've seen in the Medicare-based fee schedule states. So it's pretty clear that the combination of states basing their fee schedule upon Medicare and Medicare's reduction in reimbursements is having a positive impact on workers' compensation costs. Now I'm going to switch gears and compare radiology between the acute injuries and the complex injuries. I have the same blue bars for price, orange for quantity, green for cost as I did before. The acute injuries, all the differentials are modest, less than 110%. However, for the complex injuries, the differential is 179%, driven primarily by the average price differential of 138%. We were wondering why the average price would be so different for complex versus acute, and when we drilled down, we found that there are certain more complicated MRI procedures, usually using contrast, that are done much more often in complex injuries in workers' comp than in acute injuries. They're done more often also in complex injuries than in group health, and the cost in work comp is much higher. So that's what's driving the price differential in radiology for complex injuries. Now if we take the same approach and turn our attention to physical medicine, we see that we have a 265% cost differential for acute injuries versus 310% for complex. So that's about 15% lower, but 265% is still a big number. The quantity in both cases is around 270%, leading to a total cost differential almost triple. When we drilled down, we found that among the 12 injuries, work comp patients are 45% more likely to receive physical therapy. And when they do, they have 50% more visits, 20% more modalities per visits, and they cost 37% more per visit. Now, I can't help but think the cost-sharing mechanisms of group health play a role here. Unfortunately, I have a fair amount of experience with physical therapy under my group health plan over the years. My plan's copay per visit is $45, which works out to be like $135 a week. And when I hit $500 out of pocket, I'm pretty motivated to learn how to do these exercises at home. Now let's turn our attention to the experience rating plan. I think you all know that the experience rating plan uses 3 years of history to forecast losses in a future period. You know, this is a form of predictive modeling that was implemented decades before the term became popular. The first thing to know about NCCI's experience rating plan is that the current mod performs well on average across all states, across all risks. What do we look for in performance? We look for two things. We look for predictive power, we look for accuracy. By predictive power, I mean risks that have low mods should have an expectation of low loss ratios before you apply any experience credits. Risks with high average mods should have high loss ratios prior to application of experience rating debits. Accuracy means that once you apply the credits and the debits, the loss ratios of both groups tend to equalize. Now let's talk about how this slide supports that assessment. What I've done is taken all the risks, sort them in mod size order, and divide them into 5 equal groups called quintiles. Each group has 20% of the risks, and the first bar is the bar with the lowest mods on up to the last bar having the highest average mods. The orange bars are the loss ratio of these 5 groups before credits and debits. The blue bars are the loss ratios of these same 5 groups after credits and debits. So for predictive power, I want to see that the loss ratios before credits and debits really are differentiated. That manifests with a steep line between the bars, and we do have one here, so showing good predictive power. Likewise, after I apply the experience rating credits and debits to the different groups, the loss ratio bars, the blue bars, look flat. I've equalized them pretty well. So that tells me that the mods being produced are accurate on average. Now let's look in more detail. We'll look at it by industry group. We have manufacturing, contracting, office and clerical, goods and services, and miscellaneous. I've used the same approach, divided each industry group into 5 equal size groups after sorting it by mod size. And I see that the orange bars, the loss ratios before applying the mod, show that same steep pattern. However, I'll note that for office and clerical and contracting, there's a little flat between groups 2 and 3. So it's not differentiating quite as much as I would like in those areas, so room for improvement. If we look at the blue bars and assess how even they are, I can see that for most industry groups they're pretty good, but for office and clerical, the first 3 groups have loss ratios below average after applying the credits, indicating that a bigger credit would be needed to level the loss ratio. So another area of improvement. So now I want to extend this approach and look at different experience rating plan options. We're doing a lot of research right now, and one of the things we wanted to evaluate was longer claims history. So this slide focuses in on small risks, expected losses in the experience period between $10,000 and $40,000. That's a 3-year period, so the average loss is $3,000 to $13,000, average expected loss, sorry. Pretty small, and we know on these small risks the loss ratio is either 0 or a big number. So instead of focusing in on the loss ratio, we decided to just look at whether it was claim-free or not claim-free for different periods. So we did a similar approach. We divided into 3 groups this time. They're not equal, but the concepts still apply. The first group is 3 mods in a row claim-free. If you think about it, when you get a new mod, the experience period it's based on drops off 1 year and adds on another year compared to the prior mod. So 3 years in a row claims-free is equivalent to 5 years claim-free. That's the first group. The second group is the latest mod is claim-free, but not all 3. And then the last group is the latest mod isn't claim-free. Again, orange bars before application of credits and debits, blue bars are loss ratios after applications of credits and debits. We see that nice steep pattern indicating that there's predictive power in looking at the longer claims history. If we look after the credits and debits, we see that the loss ratio of the first group isn't equalized to the other two because the experience rating plan doesn't differentiate between 5 years claims-free and 3 years claims-free. So we're going to think about how we can leverage this insight into the design of the plan. I want to extend this concept and talk about med-only options in the experience rating plan. To do that, I want to develop a simplified metric. So this is the same slide I showed at the beginning, all risks, all states, just to illustrate. I'm going to simplify it and just measure the difference between the first and last quintile's loss ratio. That's the vertical blue arrow, and I'm going to copy it over onto this graph and do a blue vertical bar, which I'm labeling current 30%. Once again, this is the same set of small policies that we were talking about on the prior slides. So why is 30% labeled current? Well, the current treatment of the med-only losses in the experience rating plan is that we take the face value and multiply it by 30%. We made this change a while ago to promote reporting of small med-only claims. We didn't want the situation where the penalty to the employer from the higher premium for the 3 years that small claim was in the mod calculation to be bigger than the cost of the employer paying out of pocket for that claim. 30% is the sweet spot for an average risk around where that's break even. So that's the predictive power of the current plan. Someone said, well, what if we simplify the plan and eliminate med-onlys altogether? Well, we see by the 0% bar that we lose some predictive power. Now, what if we didn't prorate it by 30% but used it at face value? That's the 100% bar. We gain predictive power, but we didn't stop there. What if we amp it up by 200%, 300%, even 500%? Each step we scale it up, we get more predictive power. Now, 500% really isn't a practical option for the experience rating plan because of the potential inhibition on claims reporting that I just talked about. But it does show that for these small risks, where you don't have a lot of information because there are likely very few claims, if at any, med-onlys have predictive power. This is a big area of focus for us this year, and you'll hear a lot more from us over the next 12 months on the subject. Finally, let's turn our attention to mega claims, those claims that are at least $10 million. I showed you this slide last year. This is the number of mega claims by accident year evaluated at 24 months. And we see that 2016 is an all-time high, at least apparently, certainly a spike. Now, because we don't have the history, this excludes large deductible policies, but we did start collecting it for 2016. And we know in 2016 there were 4 in the large deductible category that aren't on this slide. Now let's inflation adjust the same numbers. I showed you this last time, and what it illustrates is that 2016 is still a spike, but not an all-time high. 2006 also had the same number of mega claims. So everyone's asked me, what did the latest year bring? What about 2018? Well, 2018 gives us two numbers. It gives us accident year 2018 at 12 months. It gives us accident year 2017 at 24 months. The light blue line is the 12-month line. It's a little lower in 2018 than it was in 17, in turn lower than 16. Too early to draw a conclusion, but we were happy to see it. Likewise, 2017 has dropped at 24 months quite a bit from 2016. And perhaps just as important, the gap between the two lines, which is the late emergence of these claims, has shrunk and is getting closer to the historical run rate. I mentioned that large deductibles mega claims aren't on this slide, but there's only been one large deductible mega claim in the last 2 accident years. So that has also dropped down. NCCI is collaborating with other organizations to enhance our database of large claims. And as once again, this is another area of focus. We hope to have a study on excess loss development done at the end of the year. Well, that concludes my presentation for today. I want to thank you. You've been a great audience. I'd like to invite you to the Meet the Experts area by the Rotunda, where my team will be available for a Q&A session. Thank you, and enjoy the rest of your symposium.